known as Society for AIDS in Africa, or SAA, TB People Zimbabwe, and CNS. We all know that TB is preventable and curable. But for 2.5 million people in Africa who got active TB disease in 2023, TB was not preventable. And for almost 300,000 people in Africa who died of tuberculosis in 2023, TB was not curable. Likewise, for HIV, which is preventable and treatable, we have science-based tools to prevent, diagnose, and treat, care, and support people with HIV. So no one should die of AIDS-related illnesses, and no one should get newly infected with HIV. But in Africa and Middle East, in 2023, 663,000 people got newly infected with HIV, and almost 400,000 of them died of AIDS-related illnesses. So while in this region, new infections were over half of those reported worldwide, number of deaths were around 64% of the global deaths. When we have science-based tools to prevent TB and HIV, diagnose and treat both of them, then even one TB or HIV death is a death too many. We have less than 5.5 years left to end AIDS and end TB and deliver on all sustainable development goals. To achieve this, we have not only to fight the HIV virus or TB bacteria, but we have also to fight myriad forms of inequities, injustices, and racism that impact lives of people in the global south. It is time for Africa. Africa has shown the world by building strength in struggles against racism, inequities, and injustices, and leading the world towards social justice and rights. Let us hear more from our esteemed speakers how Africa can overcome challenges and lead the world towards ending AIDS and tuberculosis. We have with us, I now invite Tariro Kudatsa, who is from TB Zimbabwe, and she's also on the Community Advisory Panel of International Union Against Tuberculosis and Lung Disease. Over to you, Tariro.
Thank you so much. Can you hear me?
Yes, very clearly.
Okay, thank you so much. Okay, so this is quite an interesting topic where we are talking about it's time for Africa to end the TB and AIDS epidemics and lead the world. Why are we saying that? I think there are some disparities when we look at the global north, the progress in the global north, and the progress in the southern regions. But the question is, why are we still talking about TB and HIV? Why HIV? Why TB? TB and HIV remain among the world's deadliest infection diseases despite being preventable and treatable. As much as we say we don't have a vaccine for HIV and AIDS, but I think as a global, we have able to contain HIV in terms of vulnerability and so forth. But also, when we look at TB and HIV collaboration, we find out that we are struggling to eradicate TB, yet it is preventable, it is treatable, and also proven science-based tools and person-centered approaches exist. We have a lot of science-based tools. We have a lot of interventions, initiatives, person-centered approaches on board. Yet, millions, especially the global south, continue to be affected. So what's the global divide, north versus south? Or the global north incidence and mortality. We find on TB, they've got a marked decline, low incidence and mortality. Whereas global north, global south, sorry, it's global south, global north is marked decline, low incidence and mortality. And global south, the TB, we have got the highest burden globally Africa around 25% of global TB cases and 40% of TB death. And this scenario is not quite healthy. And given the fact that TB is preventable and it is also treatable, and we've got a lot of these tools, scientific tools, patient-centered tools. We've got our CLM to monitor accountability. But why are we in this scenario? And if you look at HIV and AIDS in the global north, there's a significant drop in new infections and death. On the other hand, sub-Saharan Africa, 67% of global HIV cases and 60% of AIDS-related death. So why are the gaps still persist? Number one, resource limitations. And given the situation we are in now, funding, infrastructure, and workforce shortages is one of the key why these gaps still persist. And also social determinants, we're looking at poverty, gender, inequality, and stigma that impede access to care. And the stigma is the greatest barrier, yeah, in TB and HIV. Regardless of all what we are doing, we have been doing, regardless of even the progress we are making, but stigma remains the barrier to impede access to care and services. Then also there's an issue of policy and implementation gaps. There's delayed adoption of WHO in recommendation, some person-centered and rights-based approaches. Uh, Especially when we look at new vaccines, and when we are looking about other new treatments and so forth, we see we are not on the same page, the global north and the global south and so forth. For example, in HIV, some are on injectables and so forth, while we are still grappling in Southern Africa and some countries to 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 change our people living with HIV and AIDS to new rearrangement, especially the aging one, the 50 plus, all these issues. But in some countries, they're already having injectables and so forth. So when is Africa also going to be on the same page with the other people? And when will be WHO adopt some of these new interventions, vaccine pipeline, the new tools that are in the pipeline? When is Africa going to be part of all those tools? Then our biggest issues when you look at communities and people living with the diseases, HIV or TB, and other comorbidities, the gender and rights, the women issues, the girls and marginalized groups face disproportionate barriers to prevent care and prevention and care. This also aggregated to policies. When we look to young people, there are some policies that are not confirmed to their rights for them to to access services. What I've just said is not just is is everything. There's a lot. This is why I think some people on our panel discussion will add more, but this is just a snapshot of the barriers that is impeding us to combat HIV and TB. So what are some of the solutions that are there? Science-based, person-centered solutions. I think diagnostics. We have got a rapid molecular tests, integrated TB HIV screening, community-based testing. On treatment, we now have shorter photo reagents and oh, I lost my I lost sorry, I lost my slide. Sorry. Okay. Okay. On treatment, we now have shorter, safer TB regimens, universal access to antiretroviral therapy for HIV. And on prevention, we have pre-exposure prophylaxis, PrEP for HIV, prevention therapy for TB, and harm reduction interventions. Care and support, we've got peer-led models, differentiated service delivery, gender transformative programs, and community engagement, where we empower affected communities to lead, monitor, and innovate responses through community-led monitoring and other initiatives. But the question remains, why are we not getting there? Why are we not reaching our targets? Why are we not coming up with our why are we still having this death? Why are we still having these new infections and so forth? So hence we have got all the tools and all the solutions in our hands. So the way forward, I think we need to scale up proven interventions, universal access to diagnostics, treatment, and prevention. We also need to invest in health systems to strengthen our primary care, supply chains, and health worker training. And through that also, by investing health systems, I think this is where we are going to have a great challenge as nations, as Southern Africa and so forth. But we have got a lot we can do. Our domestic financing, how can we enhance our domestic financing for us to invest in health systems? How can we also work with the private sector to be part of the agenda so that we invest in health system strengthening to strengthen the primary health care? Also, we need to promote rights and equity, remove legal and social barriers, address gender-based violence, and prioritize vulnerable populations in their diversity and also looking at disease-specific key and vulnerable populations. And lastly, accountability and leadership. Governments, donors, and communities, we must collaborate to close the gap and accelerate progress. As I conclude, no, I quote, no one should die of TB or HIV with people-centered, rights-based, and gender-transformative approaches. We can end these epidemics if we act with urgency and equity. And as communities, as people living with the disease, we say, regardless of the cost, regardless of these barriers, we could keep the light on. We'll keep the light on, and together with our governments, with our donors, with our leadership, we can end TB and HIV. I submit. Thank you.
Thank you very much, Tariro, for your insightful sharing and for mentioning the gender dimensions of TB and HIV. And yes, we have to keep the light on, and that is the only way forward. I now invite Honorable Dr. David Pagbasese Parirenyatwa, President of ICASA 2025 and former Health Minister of Zimbabwe, to deliver his inaugural address. Welcome, sir.
Thank
Dr.
you.
Pad.
I hope you can hear me.
Yes, we can hear you very clearly.
Thank you so much. Thank you, Shukla. Dear virtual participants across the world, our own partners and friends of Citizens News Services, CNS, esteemed development partners from UN agencies and beyond, honorable board members of the Society for AIDS in Africa. It is my privilege to welcome you all to this important CNS and Society for AIDS in Africa webinar, which has got a very good theme. It is time for Africa to end the TB and AIDS epidemics and lead the world.
Sir, can I interrupt a moment, sir? We cannot
Yes.
see you. Is your video on? We would like to see your face as well.
Okay.
Yes. Thank you so much.
Can you see
No,
me
again.
now?
Yes,
Yeah.
we can. Yes, yes. Thank
Yeah.
you.
See, this gathering comes at a time which is a crucial time and a crucial moment when we are less than 152 days away from the 23rd edition of the International AIDS Conference on AIDS and STIs in Africa, ICASA 2025, which will take place in Ghana from the 3rd to the 8th of December under the theme, Africa in Action, catalyzing integrated, sustainable responses to AIDS, TB, and malaria. Today's webinar and ICASA's 2025 theme are fully aligned with the Africa Union's health strategy and catalytic frameworks to end AIDS, TB, and malaria by 2030. We are aware that the AU Agenda 2063, the Africa we want, emphasizes three important areas: strong political commitment, increased domestic funding, and integration of TB and HIV services into a broader health and social protection system. It also emphasizes the critical role of women, the critical role of the youth, and the critical role of communities that are at risk, who must not only be reached, but must be actively engaged in shaping policies and programs that reflect their realities and their needs. We are all aware that there is the World AIDS Day, which comes on the 1st of December, and the World TB Day, which comes on the 24th of March. But as you look at these themes that we want to integrate the two, sometimes we wonder whether these two days could be combined and integrated to make TB and HIV responses more stronger. Why not consider a single day to honor the shared impact of these two intertwined diseases? Both remain among the deadliest public health threats in Africa, and addressing them in an integrated, unified way would better reflect the reality on the ground. We are also looking forward that with this webinar, we will explore ways where we can go forward and enhance what has been there before and look at possible new areas that could be explored. Despite the progress that we've made, stigma, criminalization, and barriers to adequate care remain pressing issues. Prevention and education must start early, particularly in senior secondary schools, and continue through every level of society. We are also aware that women, youth, and the marginalized populations must remain at the heart of our strategies to eliminate both HIV and TB. This webinar is a stepping stone toward ICASA 2025 in Ghana, a platform where governments, civil society, scientists, activists will come together to review our progress and chart a way forward. Yes, it is ambitious to aim for the end of these epidemics by 2030, to end them as a public health threat. But with shared vision, strong political will, collective action, it is indeed possible. Let us make the most of today's discussions, and I warmly invite all of you to join us in Ghana this December to recommit ourselves to the goal of ending HIV and TB in our communities. I thank you.
Thank you very much, Dr. David, for your inspiring talk. Now it is a perfect segue to listen to voices from across the African continent. We will have a panel discussion on the theme of today's webinar. And it is a great honor for me to invite the co-chairpersons for this panel discussion. As co-chairs, we have with us Timur Abdullayev, a noted human rights lawyer and public health expert who serves as the director of TB People Global. Earlier, Timur was also on the board of Stop TB Partnership. And we have with us Professor Morenique Okpong, member of Governing Council of Society for AIDS in Africa, which is the host of ICASA 2025. Morinik is a distinguished professor at Obafemi Awolowo University, Nigeria, and currently the Dean, Faculty of Dentistry. She has played an instrumental role in advancing HIV biomedical prevention options for at least 2 decades. Welcome, Timur and Morinik, and over to you now.
Thank you. And if I may, I will just allow my co-chair, co-facilitator to start, because I'm not a professor and I'm not distinguished. So, Professor, maybe you go first and then I will follow.
Thank you so much. You are distinguished, maybe not a professor. And just to correct that, I'm no longer dean. I left the office 2 years ago. It's really exciting to see the number of people that are here to participate in the seminar. And yes, it is really going to be powerful because we've been hearing experiences, lived experiences, which is often not what we hear. Yet lived experiences is what moves us into the way of community ownership of the response, because it is our response as the community rather than and giving room for the policies to coordinate what it is as. On this panel, we'll have, I think, 7 speakers. 1 or 2 people would not be able to join us. But yes, for those that will be here, we look forward to an enriching discussion. Immediately, we'll take them one by one. We'll introduce each speaker, and I'll ask my chair to please introduce each of the speakers, and then they would share their thoughts and experiences in 3 to 5 minutes. Please hold the questions to the end of the session. We have good time to really interact, and I look forward to that interaction. Please jot your points and bring them all up at the end of the panel discussion. And to note that if there are other things, if you really want to ask questions early, please put them in the chat box. We'll be addressing them and addressing them at the end of the session. Over to you, Timur, to introduce each of the participants. My distinguished chair.
Thank you very much, Professor. First of all, also a small correction. I'm not director of TB People Global. I'm just a humble board member. Yeah, it's okay. I don't mind being promoted. So we actually have. We were supposed to have 8 speakers, but I'm afraid Chief Austin Abifuna is not on the call. I don't see him in the participants list. Chopra, you are muted.
He's present.
Oh, my chief. I am so sorry. I was trying to find your name in the list of participants, and I was afraid, like, oh my God, my best chief. I don't know many chiefs, but the best chief of all the chiefs I know is actually here. Chief Austin Arinze Obiefuna, Executive Director of ACT, and also Vice Chair of the Stop TB Partnership in Geneva. He's going to be our first speaker. Then we will have Michael Wolosimbi, who I know really well from TB People Uganda. And then we will have Norman Kagiso Matiting from TB People Botswana, also a great activist and a wonderful person. Then we will also have Tariro, who has already spoken, Madam Tariro, the alternative board member in the Stop TB Partnership board, representing key and vulnerable populations.
Timur, can I interrupt, please? Sorry to interrupt. Yes. I think Tariro is not there on the panel. Tariro is
okay.
not on.
So, okay.
Yes.
So that's unfortunate, but I was hoping to have Tariro once again, but that's okay. That's okay. I'm not changing the agenda. So then we are also going to have Evelyn Kibuchi, who's Chief National Coordinator of the Stop TB Partnership in Kenya, and Albertina Nyatsi, Positive Women Together in Action in Eswatini, and also one of actually very active members of TB People as well. Carol Nawina. Carol Oh my
It's
God,
not.
Carol is like she's not here.
She's not there. Yes, she has not come. Yes.
Okay, okay, because I was going to start like a 5 minute description of all the roles she has, but she's not here. Okay, that will save us five minutes.
But we also have Tanaka Mokova in place of
Tanaka.
Teriro.
Oh, okay,
Tanaka.
Tanaka, who's the board
Yes.
member of Stop TB Partnership, representing the community of people affected by TB, a young person, and a great guy, a great activist. Tanaka, hello, hello.
And we have Ola Bamiji Jamlu.
Ola
Ola,
Bamiji is here from
yes,
Nigeria. Yes.
Nigeria. Yes, yes.
Wonderful. So everybody, it's so exciting to have you all here. And as a fellow African, I wish I would love to give floor to first of all to Chief Austin Arinze Obiefuna. Maybe let's start with one thing that you could say about a positive difference that you made in advancing person-centered or people-centered TB and or HIV responses on the ground in your countries, maybe in the region, which I think is a very relevant point for Chief Austin Arinze Obiefuna, maybe even globally. So if you could just give us what kind of positive difference you have made in advancing people-centered TB, HIV responses in your country, in your area, in your continent. So, Chief Austin, please, welcome.
Thank you very much, Timo, my favorite person. First of all, let me say good morning, good afternoon, good evening, wherever you're joining from. And to say thank you to all the participants for joining, because I was looking at the number and I could see almost about 200, 178. That's quite a number, actually. And also, I want to say thank you to the organizers of this particular webinar, because I think it is quite due and very timely and important that we start thinking about how to integrate, positively this time around, meaningful integration, not just integration by saying like we've been seeing in the past, but meaningful integration. Because I've been in the forefront of hoping that we will see integration happen really, like the way it's supposed to happen on the ground, not just cosmetic integration of TB, HIV, and other diseases as well. I must say that uh, this webinar is also timely in the sense that everybody, if you work in the health sector anywhere in the world, should have tested somehow from the political atmosphere that we have, currently, and also with health financing, over globally, coming from the U.S. interruption, from USAID, PEPFAR, and all the rest. So once you are in that space, you know that it is time to re-strategize, because we're in a very dynamic world that we need people to think through, on strategies that to be able to mitigate such. And it's also somehow taking us back to basics, because I remember those early days when we were, focusing on TB, HIV intervention, even through the time of building formation of CCM when Global Fund started and the rest. We've seen a whole lot of movements. Some came and gone, some are still there, sustained due to their meaningful uh, uh, contribution within the health space, and especially within the TB and HIV health space. When I was the CCM vice chair in Ghana. I want to focus, I'm from Nigeria, but I've lived in Ghana, worked in Ghana, I worked in Africa anyway, but I want to focus on Ghana most especially because that's where I can be able to refer to in terms of the interventions that I personally, spearheaded when it comes to TB, HIV interventions, because we are pushing to make sure that we have a CCM, a platform that is egalitarian enough to accommodate every sector of the society that needs to have a voice in the CCM. I'm not saying that everybody will sit around the table, but at least we need to have a good representation of constituencies, that in such a way that people will have their voice ultimately taken up from the bottom to top approach that we see through the CCM. And it's a very good platform, for good dialogue because of the resources, because I can tell you that somebody might tell you it's not about the money, but if you don't have the money, you cannot move an inch. So that's why you see a lot of drift, a lot of people walk towards the CCMs because the Global Fund is seen as a predictable funding, not funding that comes from the public sector that sometimes never hits the account. But we all know that once the Global Fund contract is signed, we know that the money is coming, and that's why people take it very serious when it comes to that platform. So I was able to make the civil society, especially from the civil society view, as a vice chair, that they should not be fighting as individual diseases. They should learn how to complement each other instead of competing among each other. Because the platform, the reason why I say this is that I was the chair of the HIV TB Oversight Committee. And we were supposed to undertake a HIV oversight. We were waiting for the vehicle to arrive, and the vehicle that arrived was a malaria vehicle. I mean, written malaria program, and it's the same global fund. And people started saying, this is a malaria vehicle. Where is the TB vehicle? Where is the HIV vehicle? And I said, what is this? This is from the same institution, from the same port. So what it means is that we have not even learned how to integrate at that level. So why are we preaching integration at that lowest level? So it gives me a lot thinking that probably we are not understanding that we are supposed to become, because in some situations, it could be one person having TB, having HIV, and also having malaria at the same time. So do you want the person to be disintegrated in that form? So I gave a strong um, understanding about how we should approach than rather duplicating efforts. We should learn how to maximize the little resources that we have at that early stage in time. That led to some of us being part of the Global Fund, TRP, and also pushed for TB HIV integration. And we knew how that happened in terms of the TB HIV integration. People, TB community will be in their space writing, while the HIV community will be in their space writing. At the end of the day, they bring the proposals together without even understanding what is in terms of what the impact of that proposal is going to yield in the country. What is the problem in terms of the TB problem we have in the country? What is the HIV problem we have in the country? Do we think that we can actually move money from TB or maybe from HIV to TB to make sure that the interventions are well catered for? Or do we still retain the little envelope that we have? So these are certain areas that we need to think through. And that's why I loved, we talked about this platform. I said, this is wonderful. We should even learn because we already seen the marriage between TB and HIV. And we would not be the people, humans, because the disease have already decided to marry themselves. We should not be as humans. We should come together to fight them, and rather than disease, divorcing in the sense of allowing the diseases to thrive, you know. So I want to use this opportunity to say that it is a good platform for us to now start thinking about how to ultimately integrate TB HIV to maximize the little resources that we have. Africa already, we know that it has the highest burden of HIV associated with TB. So if we don't even have any other thing to do, we need to fight this seriously. So in order to be able to come out from that space, we need to be able to cater for people. If you look at TB HIV in Africa, it's like we're just scratching the surface. We are not pushing because MDR, we're just even talking about MDR TB is also on that space. So we should look at how collectively, as a continent, how to approach it, because at the end of the day, we still need to be able to bring in the African Union. We need to have a very collective effort approach, in order to be able to fight these two diseases. And if Global Fund has also come together, as one to say that, think through this. If other diseases have created the niche, UNH Stop TB Partnership have come to say, let's work together to be able to do this. Why can't we, both civil society, public sector, work together on this? And I have had such experience in such a way that when we work together, we're able to save a lot of resources. Thank you.
Thank you very much. Thank you very much, Chief. And I wish we could actually have more Chief Austins in other parts of Africa and also in other parts of the globe, because the CCM is a wonderful idea. It's a beautiful idea. And of course, it had certain challenges as this completely new institution appeared in our countries, right? And then there's challenges sometimes, like people are even saying like CCM is not working. Well, sometimes, yes, there has to be some work done for the CCM to start working. But as you said, it was really a breakthrough. It was the platform where representatives of the 3 disease communities could come together and work together. So that's really a beautiful thing. And I want to say that also one other thing that you didn't mention was also the key populations. And some of those key populations, you rightly said, they face multiple health issues. We have people living with HIV who have TB and malaria. So, we have people who use drugs who have both HIV and they're at high risk of TB. So, yeah, hopefully, maybe Chief Austin, we will be able to actually paratroop you to some other countries so that you fix the CCMs there, like you built the CCM in Ghana. Thank you very much. So let me move on to our next speaker, and that would be Michael. Michael from TB People Uganda. Are you with us?
Hello. Yeah, hello.
Yes, hi. How are you? One thing that you know is that Michael is also a person of many talents. He's also a singer. So he's a big fighter. He's putting his voice literally to the fight against TB. So Michael, please.
Thank you. Thank you. I'm like really honored being part of this. I feel like it's a good chance given to me. So I believe if we do such things, or maybe we'll find ways of talking on how to take Africa in the next step of fighting TB and HIV, I think we can achieve. Today, I'm here at least to highlight what we should do, or we should put in more emphasis on how to end this, how we can end TB and HIV. This is something we need to focus on. Mostly, I'm putting a bullet, or maybe putting it on my point of strengthening health systems. This here is a point that we need to put on more emphasis, increasing funding, improving infrastructures, and commonly health community, or like engaging community engagement. by raising awareness. This is something that I've been doing for a long. Through my music, I've even written some books to raise the awareness about such things. I know if we involve in the community, we will achieve what we need to end this disease. But mostly, again, what we are forgetting mostly, when we look on the population of Africa, the youth, the percentage of youth is rising and is at a high number. I think we need to empower the youth, getting them in the race to respond to end TB and HIV. By this, I think we can achieve our goals. By implementing these strategies, I strongly believe Africa can make significant progress in ending the epidemic of TB and HIV. I would like to submit this for now. More over to you.
Yes, thank you. It was unfortunately a bit difficult to hear you because of the background noise, but thank you very much for your intervention, and hopefully you will be able to do even more work in Uganda to make sure that there is integration and there is people-centered care for people with TB and with HIV as well. Not to hijack the MC floor, the MC table, how about I give it back to the distinguished professor, to my co-chair, to continue running the session.
Please do, Timo. Please do continue. I love listening to you, especially that you know the participants. It is my pleasure to have you please introduce everyone. Thank you. Over to you.
Thank you. So our next speaker would be Norman Kagiso Matiting from TB People Botswana. Norman, you are with us? I hope we have Norman with us.
Hello.
Yes. Hi, Norman. How are you?
I'm good. I'm good. Thank you, Timo.
So
Long time.
please.
Okay. I will only share with you interventions that TB people think can help us in fighting HIV and TB. The first one would be enhancing health workforce education and training. The second one will be integrating community health workers. And the third would be strengthening health systems. The fourth would be fostering multi-sectoral collaboration. And the fifth one would be promoting research and development. The next one would be advocating for policy change. The next one would be community engagement and involvement. The next one would be leveraging technology and innovation. And the last one would be monitoring and evaluation. So in conclusion, achieving these goals as they relate to health issues such as HIV and TB in the global south necessitates a concerted effort focused on building the capacities competencies of the health workforce and community structures. By implementing a wide array of strategies that include education, community involvement, multi-sectoral collaboration, and leveraging technology, we create a comprehensive and responsive health ecosystem. So it is crucial for governments, international organizations, and communities to remain committed to these efforts in ensuring sustainable health solutions that pave for a healthy future for all. I thank you.
Thank you. Thank you very much, my brother, for the intervention. I would say that all these things are very right. I just wish we had the resources to do everything really intensively and move forward. I see Mayowa with us, and Mayowa is unmuting himself. Mayowa, do you want to say something?
Hello, Mr. Chair. Can you tell all the speakers that they should kindly check their camera when they are speaking? You know, it will
Yes,
help.
that's a good idea. But I assume that people are probably connecting from various locations, so it might be a bit challenging. So yeah, if you could make sure that your camera is actually facing, looking at your face, that would help. And also, ideally, maybe check the microphone before you start speaking. So we still have quite some time. So maybe let me give it to Mayowa. I see Mayowa, you raised your hand. So before we continue to the rest of the speakers, do you want to say something?
Okay, first I just want to apologize. It's not me, the real Mayowa, that his camera is on or that the mic is unmuted. Apparently, I shared my link with many people, and so you see multitudes of Mayowa on the call. So apologies for that. The link on the Zoom is not working, so they are using my personal link. So colleagues, if you can just rename yourself, that would be helpful so that I don't charge you for impersonation. Thank you.
Thank you very much. I thought we actually made a huge breakthrough in TB community, and we learned how to clone the best of us. No, it wasn't that. Okay, thank you very much, Mayowa. So let's move on to our next speaker, who's going to be Evelyn from Stop TB Partnership Kenya. So Evelyn, I know it is going to be probably a bit difficult to say what you have done to make a positive difference in advancing people-centered care, because you guys are doing a lot. So maybe you will be able just to give us some highlights, the most important achievements and breakthroughs. Thank you.
Thank you so much, Timur. I'm humbled by your introduction. Yeah, I'm supposed to talk about a patient-centered approach and what we've done at the country level to advance that. Allow me to use this analogy. Now, all of us, we have that dress, that shirt, that shoe that no longer fits. Or when you wear it, you don't feel like you look nice. And so you stop wearing it. It could be a shirt, it could be a socks. But other people keep telling you, you look very nice in that shirt. But personally, you feel it doesn't fit, doesn't feel nice. It is the wearer of the shoe that knows where it pinches. And that is the reasoning behind patient-centered approach. Meaning that any disease response must be spearheaded by the people who have been affected. They're the one who know where the shoe pinches. They're the one who know where the pain comes in. And I want to demonstrate this and what we have done in Kenya to ensure that the community affected by tuberculosis are taking leadership in TB response. So maybe about 6 years ago, I took leadership in mobilizing infected and affected communities in TB to form what we call the National Network of TB Champions. These are people who have been affected or infected by tuberculosis. And why do we have to engage them? Like I've said, because they have the personal experience and they're the ones who know best what is good for them in TB response. And once we mobilize them, the next thing was to build their capacities in TB response, and also so that they're able to use their experiences in advocacy. And once that has been done, we have ensured that all spheres of TB response in Kenya, we have representation from the TB champions. This includes in leadership positions like the CCM, the one that my friend Chief Austin talked about at the beginning, that we need representation there. We ensure that in all technical working groups in TB, we have representation. We also ensure in the policy making processes, be it developing the national TB strategic plan, any policy processes, they are represented. We also, we may not have done it 100%, but this is partly, what we've been able to achieve. And we also recommend that the TB infected communities should be represented, or they should have their word in the research processes, whether it's for new diagnostics, whether it's for new drugs, any new product. We have to ensure that they are involved in the same process, in the entire process, because all this technology is for them. It's not for the people who are making them. It is not for the people who are transacting in these drugs and commodities. They are the final users, and therefore they have to have a word in it. And therefore, this is something that we want to recommend because we have seen it work. Because at the end of the day, you want to ensure that that shirt is fit, you feel comfortable wearing it, that drug you appreciate, or you like it, it fits your needs when you're using it, or that accessing that diagnostics, or even that diagnostics is not intrusive, you appreciate, or you comfortable when you're using it. And that is the only way we'll be able to address things like stigma and discrimination. I know Tariro mentioned about stigma as a barrier. So ensuring these communities are fully involved is the only way to address those issues like stigma and discrimination, and ensuring that the response, the patients or the communities are the center of the response. I will stop there. Thank you.
Thank you so much, Evelyn. And I can't agree more. It's so important to have community mobilized, but it's extremely important to have the community strong enough to be able to actually communicate their needs, their opinions. And this is, I think, where Stop TB Partnership in Kenya has done a wonderful job, not just bringing people, not just creating this network of national TB champions, but also building their capacity so that their voice becomes stronger, so that they become experts, and they're not looked at like, okay, we just have to listen to these guys because, otherwise the portfolio manager will not be happy. No, but it's actually just making sure those people say the things that are not just taken, not just heard, but they're taken seriously and they're integrated into programs. So that's a wonderful thing. And I have to say that that's just one of the things you were doing, right? So it's just the limitation of the time. But I loved your example about the dress. And yeah, unfortunately, very often we are told what is good for us. Like, no, you should wear that dress. No, not the one you like, not the one you are comfortable in, but the dress that we prepared for you. It doesn't fit you, it doesn't look good, but you have to take it. So yeah, and sometimes the reason is because the dress is cheap. Oh my God, that's the worst thing that can happen. So thank you very much, Evelyn. And we're moving to our next speaker, to Albertina from Positive Women Together in Action from Eswatini. Albertina, are you with us?
Yes.
Oh, welcome. Okay. So
I'm with you.
If you could turn on your camera so that we can.
Not sure what's happening with my video. I'm trying to put the video on. It's not getting through. I'll keep trying, but I will continue.
Okay. Yes, please.
Okay. So as mentioned, my name is Albertina Nyati. I'm from Eswatini. I'm a TB survivor and I've had TB twice. I know how it is to have TB. And then on bringing the voices and experiences of TB survivors into the fold, I've been able to advance person-centered care for TB in Eswatini. There are a lot of things that I've done as a TB survivor and a woman living with HIV. Okay, one of the things that I've done was I've been instrumental in going around educating people on TB and also ensuring that communities are being tested for TB. I've also been able we've also been able to work and support health workers, including the National TB Control Program, to bring our voices and improve service delivery. We've also worked with the TB survivors to share to shape and share their personal stories of resilience and recovery, because in Eswatini it was like we're not a collective of people living with of TB survivors. So it so happened that one day we were in a meeting as women living with HIV, and then we realized that as we were talking, most of the women in the support group were having TB. That is when we realized that we had a problem with TB as women living with HIV. And then we did approach the National TB Program to say, we've discovered that we are having a problem and we need help. So that is when I started to get involved in TB work as a woman living with HIV. And then also, what other things that we have done is that we've been able to form TB-specific support group. And I know that people are like, why do we form TB-specific support groups? Because TB is curable. But we always explain to them that we have issues like what we call fibrosis, whereby as a TB survivor, you have TB and it is cured, but the damage in the lung remains there. And then you continue to need support as sometimes you find that the lungs, they don't completely heal. And then also we have been able to ensure that there is a policy to influence policy. We voice our lived experiences to policymakers, influencing them on person-centered approach in TB care, and also ensuring that the guidelines they include TB. We're also a member of we're also the focal point for the Eswatini TB Parliamentary Caucus, where we work with the National TB Parliamentary Caucus to ensure that we bring the voice of TB survivors into Parliament and ensure that we also help Parliament to understand more on TB so that TB is at the center of TB of discussions in Parliament. And then as we work, we do have challenges that we have, challenges like stigma and discrimination. For sure, TB is still stigmatized. And then also issues of, we still need to have people that are having TB, they're not working. Some of them, they don't have the necessary basic needs like food so that they can live. So we also try to ensure that we organize food for people so that they can take their medication having eaten. And then also, we also do advocacy on different issues around TB, including domestic funding for TB, where we write letters to the Ministry of Finance. We talk with parliamentarians about it, with the Ministry of Health, to ensure that there is basic domestic funding for TB in Eswatini. And then some of the challenges also that are there are issues of low case detection, because Eswatini is still at 60%, which means we have 40% that is still missed. And then also limited mental health care integration into TB. In the support groups and in the communities, we still find people who, when they have TB, they also develop mental health problems. So there's still limited mental health care integration in our services. And then also we have funding vulnerabilities. Like now we're having the freeze in donor support. So sometimes we find that the funding is dwindling. There's not enough funding to do our work. So I think that is all I can say. Thank you so much.
Thank you very much, Albertina. It's incredible. Probably it's one of the great things that it's never boring when we work in HIV and TB. Like there are so many things that need to be done. So I wish we had the resources just to accomplish it all. And then it would be a different world, probably, where we end TB and AIDS for good. So thank you very much. And let me now move on to our next speaker, Olabamiji Jamiu from Nigeria. And I will not be surprised if we will actually see our, okay, so wonderful. I was afraid that you will also be called Mayowa Joel, but that's great. Welcome, and please, the floor is yours.
Thank you so much. Just like I said, my name is Olabamiji Jamiu, and I will just want to talk about the importance of integration and how this is actually going to help us in this current situation in terms of funding. I would like to start by sharing one or two words about how we've managed to use TrueNAT in the remote locations in Nigeria. TrueNAT came into the country through Stop TB partnership, introducing new two projects, and it actually arrived at the point of need because at that particular point in time, we actually need that kind of a robust system that can actually be deployed to remote locations where we know that electricity and other infrastructure might be a challenge. And without wasting time, we deployed this 38 TrueNAT machine donated by INTP project to Nigeria, to different remote locations. And in no time, we were able to actually demonstrate the impact of this particular tool, as we realized that being a battery operated equipment, we're able to deploy it to the field and use during outreaches. And when we look at the impact around this underserved population, how to reach area, IDP camps, and we bring the data together to actually assess, we realized that in just 3 quarters, we're able to increase evaluation by 82%. And not just that, when you now come to in terms of diagnosis, that's bacteriological diagnosis, in this remote location, we're able to increase case notification, TB notification by 95%. This gave us an idea that we need to do more. We just deployed equipment to 14 states out of 36 states plus FCT in the country. So with the support from Global Fund, we had the largest rollout of TrueNAT on the continent with 333 equipment through National TB and Leprosy Control Program in Nigeria. And deployment of this equipment gave us an idea, because there is an opportunity that comes with deployment of TrueNAT being a multi-disease testing platform. And as a country, we came together and said, integration that we are planning to get services across to people in the remote location, we believe we have a tool at hand that can actually give us the opportunity to achieve that. So the discussion started among the stakeholders, headed by MLSD, that's the Medical Laboratory Science Division of Federal Ministry of Health. And we started the discussion around integration because, through that platform, on the same platform, you can test for TB, you can test for HIV, just changing the chip, you can test for malaria, you can test for human papillomavirus, plus more than 40 other parameters and on the same platform. So meaning that we can actually harmonize resources and make sure that we bring everybody together to see how we can utilize what we have to achieve more. And that is exactly the route that we're going in the country. Also, apart from that, introducing into project came with portable digital X-rays that we're using for screening, and we're able to bring in a lot of people that actually asymptomatic and diagnose them and place them on treatment. So when mobile diagnostics now came to the market with ProRad Atlas, which is a portable digital X-ray with AI, and with a platform that can actually link what we are testing on TrueNAT with what the image from the X-ray is and the interpretation from the AI, linking everything together on an EMR platform and giving the doctor the opportunity to be able to see the image, see the AI report, and also the confirmatory test result just on one click, and be able to place such patient on treatment. So this is what we can call a patient-centered approach. This is what we can call taking the addressing the need of the patient right there on the field. And this intervention we've practiced in the past, and we believe this kind of opportunity, a kind of end-to-end TB screening and testing solution, will help a whole lot of people, including people living with HIV that mostly, in most cases, do not present with symptoms that we can actually point to, and we'll be able to help a whole lot of people in those locations where we deploy the equipment to. So what I would just advise is that just like the way the country, Nigeria as a country, is doing, leading by Federal Ministry of Health, to see how we integrate and test more diseases on the TrueNAT platform. I believe other African countries and other people around the globe can take advantage of that kind of platform that can be deployed to remote location and can test that can actually assay a lot of diseases, and you get people tested right there within their community and place them on treatment in their community. It will be an advantage for other people to see how to leverage on that kind of opportunity. So notwithstanding, apart from the fact that people will have access to integrated service, and people will be happy that on one clinic visit, they're able to have all their results at once. Also, the resources that we don't have much anymore, even from human resources in the healthcare space, for even the funding that is shrinking, we can actually maximize what we have to get a better result. And then we look into the opportunity of now centralizing the data from all these platforms so that we can make informed decisions from the data that we're able to pull from all these platforms in the remote location through all this connectivity platform that can actually be incorporated into the system. So what we're trying to say is, while we are decentralizing and integrating more services on this kind of platform, we should look into also bringing the data together for informed decision and to guide programming going forward. So this is just one or two things that I believe it's important to share with this on this call. Thank you.
Thank you.
Professor, I see you want to take over from here. Maybe just one little thing that I want to say. It's wonderful to see how every speaker would highlight some element that is actually very crucial for people-centered care. Like right now, we heard about decentralization and integration. You cannot have a people-centered care model without integrating, because like it's not that I have TB and I have nothing else. I have no other diseases. I have no other conditions. I have no other needs.
All right.
It's not like we all live in the capital and have access to the facilities. So I completely agree with the points you made, that integration and decentralization are really key to people-centered responses to HIV and TB. So Professor, do you want to take over and maybe
Thank you,
continue?
Timur. I did enjoy listening to you, and I did learn through your lens. I see that the people are dropping. Please don't drop, including all the Mayowas we have on. Please keep up. The more Mayowas we have, the more merrier the spaces. Please do not drop. This is an interesting session where we can hear from you and ask clarifying question. The speakers have said a lot. If there's any recurring things we've heard voices, domestic resourcing, integration, multi-sectoral collaboration, research and development, policy change, stigma. What is this beyond words? What is this beyond words? I'm sure I've heard the word of integration forever, but what is this beyond words? We'll start first by directing some of the questions we have received to the speakers, and then come up to ask other clarifying questions. Many of the questions are not. Yes, please.
Sorry. I think Tanaka is there. She was one of the panelists and we have not heard her. Sorry for this interruption.
No problem. Over to you, Timo.
Yeah, actually, Tanaka, if you could, because I was using the old list. Shoka, thank you so much for actually pointing. Tanaka, we almost left youth behind. Oh my God. So let me fix that. Tanaka, do you want to join the conversation and bring your perspective, the difference you made in promoting people-centered care?
Actually, I just wanted to say that you are forgetting young people, which is what we are advocating against, for not including young people in key decision-making processes. So thank you so much, Timu, for this time. So I have managed to contribute towards.
Oh no. I hope we haven't lost Tanaka.
I think we'll create a space when he comes up. If he's gone now, he definitely will create a space.
Yeah.
Shoba, would you please help look out for him? Whenever he comes, just signal, and then we'll choose to listen to the voice.
Yes, I will. You please continue, Moranik. I'm sorry for interrupting you in between. Sorry.
That was an important interruption. I'm very glad you did interrupt us. So yes, we have questions. And the first question will go to Tariro. The other 4 questions that I have here is not directed to anybody in particular. And so I would ask that once I raise the question, if there's anyone willing to respond, including the panelists and the panelist organizers, please feel free to respond to these very important questions. For the first speaker, we have someone ask, with respect to your reference to lenacapavir, the HIV lenacapavir, this individual noted that I would love to know what different countries are doing about adopting the long-acting lenacapavir, because the first speaker indicated this for TB, but I guess it would be nice to see how what is on the table and discussions around adoption. Over to you, Tariro. Tariro, are you there?
Professor Morini, can I chip in?
Yes,
okay.
So could you repeat the question?
Okay. Bobby, you wanted to say something?
Yeah, I just wanted to quickly update that the lenacapavir, as Professor Morinik and many others have been calling for HIV prevention options, biomedical options, which are more person-centered, especially for women and girls and gender diverse communities. Lenacapavir, as we all know, has really proven is a huge hope for all of us. because it almost 99+% of protection against HIV it has shown in 2 studies, purpose 1 and purpose 2. However, the price was $40,000 per person per year. It is an injectable PrEP, pre-exposure prophylaxis, to prevent HIV transmission, but the price was $40,000 per person per year last year. So the company has given voluntary licenses to 6 companies, and those companies are probably saying that they will be able to produce generic company. 4 are in India, 1 in Pakistan, and another one I think is in Egypt. Please correct me. So the production may probably by the end of next year, hopefully. And United has just posted a call last week, I think, asking for expression of interest in how to roll out lenacapavir PrEP in Africa. So this is just a small update. Over back to you all. Sorry.
I think it's an excellent update. I think it's an excellent update. And one of the things you might be seeing in terms of the speaker is that more and more countries are putting this in their policies, knowing very well that once you put it in the policies, it also translates largely to budgetary allocation for the acquisition. I think one of the things we might want to be talking about, lenacapavir, with respect to domestic resourcing, like the speakers noted, the changing in the funding landscape there is. What does this mean? In the past, this kind of products, once they are rolled out, are largely dependent on USAID to support the rollout in countries. Right now, USAID is scrapped. So what does it mean for countries to start to adopt, at least in the absence of commodities? Let us as advocates start to put for inclusion of this product, even in the policies. That will be a start. Then from the policies, a different set of advocates can then take things to look around what it means for financing the rollout. But yes, I think we're moving in the right direction. Thank you for that brilliant question. We have another question from Takamani Moyo. Apologies, I have no intention of massacring the name. Please, I do apologize. But the individual is from Pata, based in Zimbabwe. He notes that his question goes to the chair of ICASA. And please look, if you are there, please respond. The question is, what strategies are in place to involve young people living with HIV in the elimination of TB and malaria? And I think this is something that becomes very important when we're looking at integration, even at the community level. So the question is, young people are living with HIV, but yet they can be involved in the elimination of TB and malaria. What is ICASA's plan and strategy with respect to involving young people? Over to you, President, or Luke, are you there? If you can give a response.
And then maybe we could go back to Tanaka, because Tanaka is back. So after President, we will maybe
excellent. Okay.
Tanaka.
We'll take Tanaka. All right. I'm not sure we can hear the voice of the President or Mr. Luke, but being on the board, I can assure you that one of the 2 things
yes,
okay. Mr. President, over to you. Yes, please go ahead.
I'll respond when you're ready.
No, I'm very ready. Please, after you.
Yeah,
please go ahead, sir.
Well, for us at ICASA, one of the biggest constituencies that we cater for are the youths. That's why we have some competitions specifically done for the youths. And we train youths in many skills per country. But more importantly, it is our mobilization of governments through ICASA. That is why every ICASA meeting, you have the president of that country coming to officially open ICASA meetings. And the ICASA meetings are attended by upwards of 12,000 people. And at that meeting, that's where we then advocate through the various governments about young people's roles. So to us, ICASA is a big platform to mobilize not only resources, but to mobilize the young people through the governments, their governments, so that governments know that they've got an obligation towards their young people. And this has worked to us very well. So we are expecting this year that President Mahama of Ghana will come and officially open ICASA. And at that platform, we may expect other presidents to join in. If not other presidents, but certainly certain ministers of health or ministers related to HIV and AIDS will come to this meeting. And this is why we lobby them, including for young people, for women, for people with disabilities, and for all marginalized groups.
Thank you so much, Mr. President, for that brilliant answer. Also, just to add that remember that ICASA is a platform, or beyond the platform, actions have to happen. And therefore, young people themselves, whose capacity are being built, needs to continue to push that from taking from the commitments that they often make at this platform and helping them to turn those commitments to realities. Thank you for reminding us of the need for ICASA to do more beyond just making the space, but also promoting integration in the actions of young people living with HIV. Thank you for that brilliant question. We have another question here. I can't identify the speaker. Oh, I think it's also Moyo.
Shall we give an opportunity to Tanaka?
Oh, yes, exactly. We'll keep quiet now.
Question.
Exactly.
Thank you so much.
Thank you, Timo. Over to you, please.
Tanaka, please.
Okay, thank you so much. Sorry, there was an interruption. And thank you so much, Dr. Parenyatwa, for the amazing work that you are doing in incorporating young people. You've been my role model since you were the Minister of Health in Zimbabwe. One of the key points that I am doing in advocacy has been advocating for the removal of user fees for young people seeking HIV treatment, and also together with Say What, which is a youth-led organization here in Zimbabwe, we managed to develop a TB rights manual targeted at young people. And these initiatives coincide with broader advocacy movements that encourage TB patients to share their experiences to combat stigma and mobilize support. And also, I have been advocating for the inclusion of young people in keyboards that addresses TB and HIV. And this also is critical because young people are often both victims and the agents of change in healthcare, targeting TB and HIV. And we are ensuring that this demographic voice of young people has a voice in governance structures, which could lead to more responsive and effective public health policies that addresses TB and HIV. And also that I have been advocating for a person-centered approach in healthcare settings, particularly in hospitals, here in Manicaland, in Zimbabwe, whereby we have I've advocated for the instrumental in managing complex health conditions like TB and HIV by tailoring treatment strategies to individual needs. So I can sum it up that we are still going as young people, and we will make sure that we are included, and also that we make sure that every part of the spaces that deals with TB and HIV young people are included. Together, we can end TB by 2030. Thank you.
Thank you very much, Tanaka. That's really a good point. And I want to say that as recently a youth, sometimes it is difficult to actually realize we're not that youth anymore. So and which is why it's very important that we do need to give space to young people, even when we think we are young enough, but we have to voice of the real young people and not some senior youth, like for instance, which is the way Chief Austin, for instance, is calling himself senior youth. So no, it's not about senior youth, it's about youth. So thank you very much for that. Professor, back to you.
Yes, and thanks for reminding us of that, and thank you for the youth participant. That was powerful. I think one of the things we've also seen about investing in the youth is that you become the senior youth that continue to push the passion and therefore continue to make a change. I would want to say that the successes we've seen in the field till date is because of the evolution of youth to senior youth to continue with the passion and continue to and dig deeper. Thank you so much for doing what you've done. There is still one question here that has to do with the young people, and the space is open to any um, panelists that could answer this question. It's also from Moyo, from Kata, based in Zimbabwe. The question goes to the first speaker, or the question goes to Tariro, please. But please, if anybody else can answer, please do. We spoke about the need to strengthen healthcare systems as a way forward. My question is, how far are African countries in terms of strengthening the health system to adopt the use of long-acting treatment options for HIV? I repeat, the question is, how far have health systems in Africa gone in terms of strengthening itself to be able to adopt and implement long-acting treatment options for HIV? Please, this question is open to anybody on the platform who may be willing to answer the question. Yeah. Anyone willing to answer the question?
Okay, thank you so much for the question. And on treatment options, sometimes we wonder. For example, we heard that in Africa, I think it's Africa, we've got the first vaccine of HIV and so forth. But because of the policies and the laws, we don't know why we are not able to take those options for our countries. And also, even if you see the quantities that was said to be have purchased or procured by Global Fund, it's quite little. But I'm not much savvy with the issue of maybe IPs and whatsoever. So, Timo, can you help me out here? I think we are a little bit savvy on the issue of um, manufacturing, diagnosis, and procurement of these services. I don't know why. Is it WHO? We really don't understand why. But I think Africa also is ready to do something on to do something for its people. But I'm not sure. But Timo, you can help me out here. I think you're a mentor in the law, IP, intellectual property, all those issues. Yeah, Timo, help me out here.
Yeah, not sure I will be a really great help, but just very quickly, I think there are different factors, but one of the factors would be the price, and that is the barrier, which is basically countries need to prioritize things they buy so that they actually make it. They cover as many people as possible, and that is probably why long-acting injectables are not yet available and accessible to people on the ground, not just in Africa, but basically in all developing countries. Which is the reason why, for instance, in terms of prevention of TB, we still have a lot of countries still using isoniazid preventive treatment and not 3-HP and other options, which are much more people-centered. So unfortunately, money is a big issue. But why money? And yes, that would be one point would be intellectual property and monopoly, because we don't have a lot of competition. We don't have a lot of generic offerings. And I see Bobby raised his hand. Probably he wants to add something else.
Yes, Bobby, please come along and then I can add one or two words before.
Yes, I'm very sorry to intrude again. So I just wanted to quickly say that we all, and Professor Morenik has been a big inspiration for us over the years on this issue, that the communities which participate in research studies, when these products finally come out of the research studies, they don't get to use these products, or there is such a long delay by when these products reach to those communities. I think it is also about ethics, and I think we must ensure that people of several African countries, for example, Kenya, Botswana, Malawi, South Africa, Eswatini, Uganda, Zimbabwe, who have participated in these studies of long-acting antiretrovirals, whether it is for treatment or pre-exposure prophylaxis, they must be the first ones to receive. And I'm coming from India. India produces PrEP and so many medicines, but in India also government has not rolled out pre-exposure prophylaxis as part of public program. It was first approved in 2012. We produce cabotegravir, lenacapavir. Those generic medicines will be made here, but even oral PrEP is not being made available as part of the national program. I think we really need to ask these ethical questions. It's time for Africa. It's time for people to get all the range of prevention options. And as Professor Morini will probably agree, it is about choice, so that people can choose whether they will like to have daily oral pill or will they like to have long-acting injectable antiretroviral therapy. It's up to them to choose from. And as over to you all. Thank you.
Thank you very much, everybody, for those brilliant answers, responses. I just want to layer on, just like Bob, we've been in this space, and I can also see Akinjimo Mayowa. We've been in this space for long. Advocacy can drive a change. Advocacy can put pressure on reducing time. We have to continue to organize ourselves to put that pressure to reduce the time of translating research into policies and actions. But having said that, please know that things are happening at the African level with a lot of focus and emphasis.
Professor, you got muted.
Yeah. I think whoever is playing funny, you can just eject them. Maya, well, a number of your people will have to get ejected. Yeah, so there's things happening at the African front, and it's not easy, but they're pushing, where there is a lot of movement to asking for diagnostics and treatments to be produced on the continent. Once these are produced on the continent, it does two things. One, it increases opportunities for job opportunities. Two, it brings local capacity to be able to do a lot more, but most importantly, it will reduce the cost of these things. So things are happening, but I must admit that at the international level where things are happening, the community voices is low. And a piece of work that is happening with SFA is showing that the community voices are missing in those spaces. We have to go again and knock those doors and get ourselves into those spaces so that we can forcefully transact things like in the clinical trial space. Our voice is not there. We are generally, but in those other clinical that is affecting diagnosis, treatments of other diseases or other importance, responses we have to get into. The voices have to be there. It also means building our capacity to be there. But all the time, funds for community action is always falling off the table, all the time. But we must not keep quiet. That is why this platform, I think, is very important. This platform is helping us identify where there are gaps that we can mobilize action. And I want to challenge ICASA. Please listen to the words that are coming here and organize some of those sections. Even if it's properly organized, please dedicate 1 or 2 sections at ICASA to address the issues that are coming here. Thank you, everyone, for the questions. We still have about 4 more questions. I will raise them. This 1, 2, 3. There are 4 questions, but they're not directed at anybody. Please, once again, everyone who has an answer, please raise them. This is a question from someone who says, I'm concerned that TB prevention strategy in Africa is not being discussed for scale at population level. Countries like South Africa and Zimbabwe has almost 90% LTBI prevention, but we're not eliminating at the prevention level. Considering the HIV incidence rate, we should consider general population level strategies in my option. So please, do anybody, including Timur, do you have a response to this very important question? Over.
Maybe I can jump in.
Yes.
Oh, yes, please go ahead. Please go ahead.
I will just follow.
Thank you. Yes, I really relate with the person who has asked that question. And I think the biggest problem is that we have not created enough awareness, sensitize the communities about TB availability of TB prevention so that the demand comes from the communities. And I want to give a very good example. When I was growing up, we were very much aware that if you're to visit a place where there is malaria, you needed to take a prophylaxis. We actually went to the shop, bought, without being prescribed by anyone. Because the danger of malaria had been driven into us that we actually demanded for it. We didn't have to be told. I think we need to sensitize the communities, the citizens, to such a level that they're the ones who are asking for it. They're the ones who are demanding for it. They're the ones who are demanding even for better preventive interventions. They're the ones demanding for research for better interventions. So I would urge that when we are creating awareness about the signs and symptoms of TB and whatever, let's prioritize the need for prevention as a message that reaches every citizen. Thank you.
Yeah. Timon will come on now just to add to what Evelyn notes. I think what I've seen over the years is that evolution of community educating themselves, independent of the sources of funding from the government or the partners. In my own generation, I'm a lot older now. When I started, it wasn't about the money, it was about the passion to make things happen in your community. So you drive change and educate because you need them to know to take action. Now, if there's no funding, you don't do anything. Whereas these things are important, and there are lots of things you can do without the money. Evelyn, thanks for raising that. The people on the ground needs to know to act. Once the masses act, the government will respond. We're just a little number when we say we're advocates. The masses are the power. So yes, we have to change our strategy to continue to translate information down to the community that they can act for themselves. Thank you. Over to you, Timo. I think you wanted to add some.
Yes, actually, I think that one of the reasons why we're not doing extremely well on the prevention side, especially in TB, but also in HIV, and which is actually one of the reasons why we don't have modern prevention tools such as long-lasting injectables. I think the problem is that there has been a lot of effort to mobilize and to strengthen the voice of key populations. But most of our investments went actually into mobilizing and strengthening the community of people living with HIV and people affected by TB, specifically TB survivors. Prevention is much more relevant to key populations, which is why it's so important to strengthen their voice, to invest into mobilizing and building capacity of key populations, because they need prevention. People who already have HIV, they may want to take care of the close ones, which is their interest in prevention. But otherwise, like for them personally, it's not really like, you can't imagine when the news about the vaccine came out, I received so many messages coming to you saying like, oh, we have the vaccine, ta-da, you are fine, you're not gonna have any HIV anymore. And I was like, no, you guys don't get it. You don't understand how it works. I'm done, I have HIV, I have HIV. It's really for people who do not have HIV. So which is why I think it's very important to increase investments into key populations, both for HIV, but particularly in TB, so that we actually were in a better place when the vaccine for TB is coming up. And then another thing is that in TB in general, unfortunately, TB infection was not really the big thing. Look at the screening we do. We do not screen people for TB infection. Imagine if we screened people for AIDS, not for HIV, but for AIDS. That's what we do in TB. We screen people for active TB. How about actually seeing who has TB infection? And then from there, build the entire algorithm so that we can actually address it. It's pretty simple. Like, you test for HIV, you don't test for AIDS. You test for HIV, and if the person has HIV, from there you actually look, maybe the person actually has an advanced HIV stage. In TB, how about we really try to see who has an infection, and then from there, if the person has an infection, then the person is likely to have will be able to have active TB. You cannot have active TB without TB infection. And if you don't have active TB, fine, prevention. If you do have active TB, fine, treatment. Of course, both ideally with counseling, something that we often forget, so that it is people-centered. And ideally, the prevention is not just like, okay, here's one option and you don't have any other option, just eat this. So, and then if the person doesn't have the infection, fine, congratulations. You can go.
Go
Exactly.
and prevent.
Exactly. So I
Thank
think
you
that's
so much.
also an important point. Thank you.
Yeah, I hope we're going to have a summary of this meeting. It's one of the sessions I would strongly advocate for at the Nice Castle session. We can't do everything here. We have just about 60 minutes to end, and we still have 3 questions. I'll go quickly through them, and yeah, hope the panelists can help answer. There's one brilliant question that has to do with private sector engagement from a young activist who says, I've noticed that a major hurdle in a TB response in terms of service delivery is the funding gap. The African region requires an estimated 4.5 billion US dollar annually, but only 0.9 billion is currently available, leaving a gap of 3.6 billion annually. And those programs are heavily reliant on international donors. With the cutback of aid funding, we definitely will be impacting on treatment and prevention. This question, or her question, apologies, I do not know your gender, is why can't we collaborate with as many African businesses and fund our own fights against TB and HIV in Africa? Because many African businesses are incorporating, increasingly embracing the robust CSR initiative. Health is a natural fit for CSR and aligning with ethical responsibilities and enhancing corporate reputation and brand loyalty. This is the submission of this young activists. Any thought about how we can do better with having the private sector embrace TB, HIV integration, as a corporate social responsibility? Any voice to this? I think for me, if I'm going to answer quickly, I think this also falls very much into the ICASA space. And I'm challenging the president as well as Mr. Luke to make this something that we're putting on the table to ask. The private sector engagement in Africa in health response in general is low, and they can do better. Now that we're looking towards domestic resource mobilization, we have to find ways of increasing CSR to health response. I'm not eliminating the music and entertainment sector. No, that's not been eliminated. But I think we can also ask for an increase in investment and do that. So we do, the ICASA conference usually has this platform of engagement of critical stakeholders. And I would want to challenge that the next ICASA looks at putting this issue with respect to private sector engagement in responding to TB HIV very strongly. It used to feature very well in the early days when we were looking at workplace response, but that has gone down. Maybe this 35th year anniversary will be a good time to resuscitate that. Thank you very much. We have 2 more questions here. One says, good morning, everyone. My name is Toga Wuda from Liberia, and I'm a young community leader actively working on the front lines to fight against malaria, AIDS, and other preventable diseases that continue to devastate vulnerable population in my country and across Africa. Given that Africa continues to bear the highest burden of both TB and HIV, despite decades of international commitments, billions in donor funding, and existence of WHO-recommended science-based tools and person-centered approach, why is it that many African governments still lag behind in prioritizing this health crisis, failing to implement sustainable health financing, integrate TB and HIV services into national systems, and enforce accountability for mismanagement of health resources, especially when the global north has proven that ending this epidemic is possible through strong governance and political will, and what immediate practical steps can be taken? I want to actually pose this question to the ICASA chair. If you're still there, sir, knowing fully well that you do a lot around governance involvement in HIV response. Dr. David, are you there?
Yes, I'm there. I'm listening intensely, but I want to go back first to the issue of TB prevention. You see, and I like, Timo, what you said about prevention and also the issue of testing. But people must recognize that the difference between TB prevention and HIV. With HIV, we know how it is transmitted. the methods, how it is transmitted. And they can be identified and you can actually pinpoint to them. With TB, however, we know it's transmitted through the sputum mostly. But then it's not as obvious as sexual transmission of HIV. So it's very insidious. And therefore, what has happened is that you try to look at where is TB most transmitted? And you find that it is among minors, crowded communities, poor communities, people who are immune compromised, children, and pregnant mothers. So you target those areas. And that's one area that we should, when you're preventing TB, those are the areas you look at. You also look at vaccination. Are we still doing BCG vaccinations? These are areas you must look at. You want to look at the early diagnosis so that you treat quickly. And the more people you treat, the more you prevent because they don't therefore spread that infection. What about quarantine? People are now saying you give treatment for so long and then you quarantine for so long. Is it effective? So you need to look at all those areas in terms of TB prevention. And those are the technical areas that we must look at. When you come to the private sector involvement, I think it's so critical that the private sector, and I must say that for us in Africa now, what Donald Trump did to us is everybody now agrees it's a wake-up call. And again, I must argue that there's no point of us Africans expecting Trump to treat people in Zimbabwe or in Nigeria for HIV. He has no obligation to. The obligation rests with our governments.
The government.
That's what we should lobby for now. Africa, wake up. Put money into the health sector. Don't wait for Trump anymore. He said it, America comes first. Now the MAGA, the make Africa great again. The MAGA should now come to Africa. We should now be ourselves looking at our governments and say, please sponsor this. So really it comes with the private sector in our Africa region. How can we integrate them in the fight against HIV, TB, and malaria? We have often neglected them. And I know there's a platform within Southern Africa where the private sector has been taken on board to do what we call prevention, co-prevention. And this is what we should be doing and expanding. So let's not leave them out. Some of them have monies, and some of them employ a lot of people, especially in the mining areas, the plantations, the dusty cement manufacturing areas. Those are the areas we should be looking at. So yeah, it's important that at ICASA we should raise these issues. And it's a big platform. And I agree with you, Morenike,
Thank you.
that let's put it to ICASA. So yeah, that's what my few comments. Thank you.
Thank you so much, Mr. President. Brilliant submission. Evelyn?
I just want to add my voice to.
Please unmute your mic.
Yeah, I'm speaking. Can you hear me? Okay. Yeah, I want to agree with the president, what he has said, and add my voice to the issue of domestic resource mobilization and say that all decisions about funding are made by the political leadership. And so our role and responsibility as TB and HIV champions, and malaria as well, is to ensure that we are engaging the political leadership at the country level. They are faced with so many priorities, security, food, whatever. And health is just one of the issues that they have to address. So if we do not tell them our needs, they may never know the gaps that there are. And we are lucky to have quite a number of platforms that we can engage the political leadership through. For example, we have the Parliamentary TB Caucus that Albertina made reference to. We have the HIV Parliamentary TB Caucus, which is in existence. So we need to look at the platforms existing at our country level and even at African level and ensure that we are constantly engaging them and presenting our ask to them and also sustaining that pressure on them, because domestic resource mobilization is the only way to go, and also promoting efficiency. We have to ensure we stretch the dollar that we already have. Thank you.
Thank you very much. Professor, are you there?
Hi, Timo. There
Hi,
is
Tarim.
Paksani Moyo Sihend. He has been up for the longest time.
Do you mean there was a question?
There's a hand, Paksani Moyo.
Oh, I actually don't see the hand. But if there was a hand up, then the person should probably speak.
Thank you so much. Can you hear me?
Yes, yes, and I'm sorry, I didn't see the hand, so I'm really sorry.
It's okay. My name is Paramani Moyo. I'm based in Zimbabwe, working with Pediatric Adolescent Treatment Africa, PATA. I hear what all the speakers have alluded in terms of advocacy and making sure that communities speak to their needs and making sure that we hold government accountable. My question is to the ICASA board and the rest of the team to say, have they also assessed the Ghana atmosphere? Is it Ghana where we are going to be having the conference to say, is it a conducive environment for advocacy? Will it allow young people to advocate, to demonstrate on these issues that we are raising today? Will we have a platform where we advocate, or the platform will also not allow for us to raise our voices as young people? Have they also looked at that as well? Thank you so much.
Okay, Timo, can I
Of
ask
course, yes.
can I ask Luke, who is our executive director based in Ghana for ICASA and Society for AIDS in Africa? Perhaps he could give us a real experience on the ground in Ghana to answer that particular question. Luke, are you there?
Yeah, I'm there. Thank you, Mr. President. First of all, let me congratulate all of you, especially everybody online there, the participants, for this wonderful webinar. And we believe that normally the webinar was planned for 1.5 hours, but now we have spent 2 hours. Okay. Saying that CASA is a platform for activists. However, we conduct this activity, in the manner that suits everyone, and you have a lot of opportunity, a lot of platform, a lot of session where you have the right to voice your issues, I think that we see a lot of call for proposal outside there for all participants at the CASA to propose their activity. The activity depends the activity that they propose. In general, ICASA is a platform for activism, and we are expecting also to have a big platform. I don't know if Chief is still there. We are proposing to have a big platform for advocacy, especially at the pre-conference with the parliamentarian at ICASA on TB. We are also proposing to host something like that for HIV, then mean that really ICASA is a platform for Africa and for Africans to voice their issues and also to work towards ending AIDS and TB and malaria as stipulated by the thematic of ICASA 2025. I will take the opportunity to invite all of you in Ghana. You will be welcome. We are based in Ghana here. You will be welcome. Let us know when you are coming so that we can welcome you from the airport. Thank you so much for your time. Mr. Chair, I believe that is the time to end this webinar because we spent 2 hours out of instead of one and a half hour. Thank you so much. Over to you, Mr. Chair.
Thank you very much. Thank you. And yes, I think it was a wonderful webinar. I'm not sure I am the chair. I was just emceeing the discussion, but at least, at some point I can become the chair. And it's flattering. It's the day I became a chair. But it was a wonderful discussion. There were so many issues brought up. There were so many ideas that were coming up from the speakers. I really hope that as President said, Africa will wake up. Africa will actually invest into HIV and TB responses, and countries will take the ownership. We definitely cannot wait for President Trump or any other president to actually save Africa, or to that matter, any other country. The responsibility is ours. So I fully agree with that message. And even though money is like the huge elephant, I would say even not maybe an elephant, it's like a whole dinosaur in the room. But it was really good that the conversation wasn't just about money. I think it's wonderful because yes, money is very important. Yes, you can do very little without money, but money is not everything. The people, and we have a lot of wonderful people in Africa, in every country of Africa, wonderful TB and HIV advocates. If what it takes is basically for someone to be crazy enough, we can change the world, because only people who are crazy enough to believe that they can change the world are the ones who do. Those are the words of Steve Jobs, and I really like them. So thank you very much, everyone. Maybe some proper African would be able to close the meeting so that it's not some white dude from Uzbekistan actually closing this wonderful webinar. Maybe we can have some voice from Africa to close the meeting. Thank you.
Yeah, you are right. Mr. President, can you close the meeting?
Yes, Mr. President, please.
Thank you very much, Timo, and thank you. Look, I think we really have had a very, very fruitful discussion, and a lot of these ideas are something that need to be implemented, and we need to look at platforms where we can implement some of these issues. There's no point us talking and no implementation. But I'm so glad that there's been over 140, 50 people attending this particular webinar. Well chaired, well articulated, good questions. And I think that I want to thank everybody. Shukla, thank you so much. Timos, thank you so much. Professor Morenike, thank you very much. Luke yourself, thank you very much. And all the participants who have presented to us, Manyoa, Joel, and others. Please, thank you so much. And we're expecting all of you to come to ICASA 2025 in Ghana so that we can continue this conversation. And then our results come to fruition. So thank you. And I want to officially now close this meeting and adjourn this meeting. Thank you.
Thank you.
Thank you. Bye.
Thank you, everyone.
Thank you, everyone. Bye, Bye. everyone. Thank you.
Bye.
Thank you, everyone. Bye-bye.
Thank you, everyone, and have a good day.
Thank you.